PCOS. I know what you're thinking. Dr. Amos is talking about politically correct office slogans. Nah. Now this is the real deal. This is the P to the C to the O to the S. Polycystic ovarian syndrome. I'm Dr. Mark Amos, and this is Taco About Fertility Tuesday. Before we start, I just want everyone to know how much I love doing this. Normally tonight, I would be binge watching my new favorite series, Big Little Lies, which was told to me by one of my patients, and I can't stop watching it. But instead, I'm doing this podcast because I love doing it. Although I am thinking about Big Little Lies and wondering what's going to happen in the next episode. But for now, let's talk about polycystic ovarian syndrome. Polycystic ovarian syndrome is a very unusual disease. In reality, it's not a disease. Matter of fact, that's why it's called polycystic ovarian syndrome. That S is a very important S. Many, many women have polycystic ovaries. But not everyone has polycystic ovarian syndrome. And the sad thing is that polycystic ovarian syndrome is not talked about much other than in fertility groups. But in reality, it's not a fertility problem. It's a medical problem. And unfortunately, most women don't talk about it until they can't have kids, and then they find out that they have this thing called polycystic ovarian syndrome. About 1/3 of the population has what's called polycystic ovaries. Now, when you hear that, it sounds like they have lots of cysts on their ovaries. I mean, the name of the disease is polycystic, multiple cysts. But in reality, people who have polycystic ovaries and polycystic ovarian syndrome usually don't have any cysts. What they're seeing is multiple follicles. So two guys in 1935 named Stein and Leventhal went and found women with this phenotype and called these little cysts and became polycystic ovarian syndrome. But in reality, it should be called polyfollicle syndrome because their follicles are not really pathological cysts. So when women get lots of cysts all the time, they say, oh, I might have polycystic ovarian syndrome because I get lots of cysts. No, if you're getting lots of cysts all the time, then that means you're ovulating and you probably don't have polycystic ovarian syndrome. So what is polycystic ovarian syndrome? Well, in 2003, there came out what's called the Rotterdam criteria. And since then, everyone uses this criteria to define PCOS. Now, to have PCOS, you have to have 2 of 3 criteria. So the first criteria is that you can have irregular periods. So this can be where you ovulate once in a while, where you don't ovulate at all, and you have what we call amenorrhea, which means no period. And it can just be irregular. The second criteria is chemical or clinical evidence of increased male hormone. So these are things like increased testosterone, androstenedione, DHEA. But you don't have to just have laboratory evidence. You can just have clinical evidence. So anytime you have increased dark hairs on your face, such as in the chin or between the breast on your chest or on your abdomen going up to your belly button or even on the lower back or buttocks or the inner thighs of your leg, those are evidence of hyperandrogenism. And the third criteria is polycystic ovaries. And that's the important part. You can have polycystic ovaries and not have polycystic ovarian syndrome. You have to have one of those 2 criteria to be able then to have polycystic ovarian syndrome. Great. So now you found out you have 2 of the 3 criteria. That must mean you have polycystic ovarian syndrome, right? No, Wrong. See, a syndrome is not a diagnosis. A diagnosis is something that has criteria, such as high blood pressure. To have high blood pressure, you have to have above 140 on the systolic side. For diabetes, you have to be above 126 milligrams per deciliter of glucose, fasting. But a syndrome does not have a specific number that you must meet. A syndrome means if you have one symptom and then you have another symptom, it's possible you have a syndrome and might be a risk for a lot of symptoms. For example, when you hear Down syndrome, most people when they hear Down syndrome, also called trisomy 21, think of happy kids who have decreased mental IQ. However, the doctor who is taking care of that child knows that this child now has increased risk for heart defects, vision problems, hearing loss, infections, hypothyroidism, blood disorders, low tone, problems with their spine. The point is, there are many, many things that now the doctor needs to look for because he knows or she knows that the baby is at higher risk for it. Well, the same thing goes with polycystic ovarian syndrome. So in order to diagnose it, you have to also rule out things that can look like it. And so even if you have two of those three criteria, you must rule out things that can look like PCOS. And those things include ruling out other things that cause irregular periods, such as thyroid problems, prolactin, hyperprolactinemia, where you hear about women who have irregular periods and breast discharge can look like PCOS because you have the irregular period. You also have to look for things of why you might have increased hair or acne, and that can be from hyperandrogenism. And so you have to check a testosterone level. You're not checking a testosterone level to prove you have PCOS. You're checking a testosterone level to make sure you don't have a tumor that is causing your testosterone levels to go very high. The same thing, you can check other hormones like DHEAS and androstenedione. Another disease you need to rule out is a thing called non-classical adrenal hyperplasia. And the way you rule that one out is you draw a 17-hydroxyprogesterone level. And if that is greater than 200, then it suggests they may have non-classical adrenal hyperplasia and not PCOS. And the important reason of ruling these out is because you don't want to treat a problem that is the wrong problem. So why do your OBGYNs always feel so sure when they tell you have PCOS and they haven't even done some of these tests? The reason is because 9 out of 10 times, if you have irregular periods, you probably have PCOS. So even a bad better is going to be right 90% of the time. So it's no problem for them to guess PCOS, but sometimes they're not correct. I have seen many patients in the past with medical problems that are not PCOS and have been called PCOS. So if there's one thing I can recommend to you, if you think you have PCOS, make sure your doctor does the right testing or see a specialist like a reproductive doctor who knows what to look for to find out if you really do have PCOS. How do you find out if you have PCOS? You test those 2 of 3 criteria. So 1, the way you check to find out if you're ovulating is you can do ovulation kits, but the best way is actually to draw a day 21 progesterone level. If this level comes back greater than 4, then you know you're ovulating, and you then don't have the criteria of irregular cycles. However, if it comes back less than 4, you can repeat that weekly until either you get a period or after 3 tests being under 4, you know you're not ovulating. Now, the reason it's better to check a progesterone level than just checking ovulation kits is because ovulation kits are ovulation predictor kits. They're looking at an LH hormone, and they can be falsely wrong. But progesterone only comes from after ovulating. So the only way your progesterone level can be up is either 1, you're ovulating, or 2, someone is sneaking in your house at night and injecting you with progesterone. Now, to define the second criteria, which is the hyperandrogenism, there are two ways you can do that. The first way, which is probably the easiest, is to do an exam. Have your doctor look over your skin. Look at where the hairs are, acne is, and see if it's consistent with PCOS. The acne of PCOS usually is on the chin and is usually hormonally related. When it looks at hair, we look at places such as around the chin, the neck, between the breast, on the belly button, below and above, on the back, on the buttocks, and the inner thighs. Another feature we look for is a thing called acanthosis nigrans. This is this brown discoloration that some women will notice on the back of their neck, under their armpit, sometimes below their breast, and even in the groin. If you have that, you may have insulin resistance, which we'll talk about a little bit later. Many doctors may check hormonal levels, such as testosterone, androstenedione, DHEAS, but you don't have to test those to find out if you have hyperandrogenism, because if you did, you're probably going to show it. Now, who wouldn't show it? Well, someone who's been on birth control for a long time. If they've been on birth control, they may have not got all the symptoms of PCOS yet because they haven't had their body exposed to the high testosterone levels. So in those women, you do need to check hormones to see if they're elevated. Now, this is an important point because I think most women think that they have hormones that of a male. I can assure you, your hormones are not that high. Matter of fact, if your hormones were as high as a man, you would start growing a beard, your voice would deepen, and your clitoris would start growing. So when we talk about elevated testosterone levels, we're talking about minor elevations. Instead of the normal number being around 50 to 60, we're talking 65, 70. These are not the level of men, which are 300 and above. If it was, you would show more signs than just a few hairs. Now, when it comes to polycystic ovaries, the way to test that is with an ultrasound, specifically a vaginal ultrasound. I can't tell you how many times I've had patients tell me, nope, my doctor tested and I don't have polycystic ovaries. I ask them, well, how did they do the ultrasound? And they said, oh, right here in my belly. And the problem is that some people who have PCOS, as a matter of fact, 40 to 75% are usually overweight. And so doing an abdominal ultrasound is not going to be good. Even on someone thin, an abdominal ultrasound is not perfect. But a vaginal ultrasound gets you so close to the ovary that you can see the detail and see the polycystic ovaries. And you see the surprise on their face when I place that vaginal ultrasound and they see their ovaries and go, oh, wow, those are definitely polycystic. Yet they were told before they weren't. And that's because an abdominal ultrasound does not have the detail to be able to prove polycystic ovarian syndrome. And so unless someone has done that, I would not rule out that you don't have polycystic ovaries until someone's done a vaginal ultrasound who knows what they're looking for. Two things I mentioned earlier. First, that polycystic ovarian syndrome is not a fertility problem. And two, because it's a syndrome, it could be associated with other issues. Now let's start with the first one. Why do I say it's not a fertility problem? The reason I say that is because this is a medical problem. Women who are not ovulating have a medical issue. If your husband was not able to get an erection, would you go to the doctor and say, my husband has a fertility problem? No, you would say, he can't get an erection and we're having a problem now having intercourse and that's preventing us from getting pregnant. Well, the same thing, if a woman isn't ovulating, there's nothing wrong with them from a fertility standpoint. Their eggs are still good. Their tubes are still fine. They're just not ovulating. So it's not a fertility problem. It's a medical problem. It's not like their body just said one day, I really don't want to ovulate. Everybody else is doing it. Why do we need to do it? Can't we just hang out all day? Why do we have to be like everybody else? No, ovaries don't do that. There's a medical problem causing your ovaries not to ovulate. Matter of fact, that issue is probably related to a bigger issue called metabolic syndrome, which we'll get into a little bit later. Now, when it comes to that second issue, the symptoms associated with the syndrome, the symptoms that come with polycystic ovarian syndrome are these. One, by not ovulating, you don't have periods as often. And when you don't have periods as often, you have an increased risk of endometrial cancer. That is cancer of the uterus. It's probably one of the most dangerous things for women with polycystic ovarian syndrome. If there is anything you can take away from this podcast and you have polycystic ovarian syndrome, it's that you have to have a period every 3 months. If you don't, you need to get medication to induce your period because otherwise you can get endometrial cancer. The second thing that comes up is diabetes. By having PCOS, you have an increased risk of diabetes. Matter of fact, you even have an increased risk of gestational diabetes, meaning when you get pregnant, there is a higher risk that you will get gestational diabetes, and that could then affect your baby.
Stay with us. We'll be right back.
Hey, it's Pat Flynn here, host of the award-winning podcast, the Smart Passive Income Podcast, which was created to help you learn how to become an entrepreneur. And in the simplest way, too. You know, entrepreneurship can be very difficult. I like to simplify things. And I interview people like Josh Hall and Shane and Jocelyn Sams and Maria Fela. Who are they? Well, they're people just like you, people who have taken action after listening to the show and have built a business that has changed their lives. And I'd love to share an episode with you that I think will inspire you to get started, too. Check out the link in the description or go to smartpassiveincome.com/122 to get inspired, get what you need to get started, and change your life. You got this, and thank you.
Another risk is that there is about a 2 to 3 times risk of heart disease by having PCOS, increased cholesterol. There's increased chances of having hirsutism, acne, and one other feature that usually gets all the limelight is fertility. Now, of course, it's going to be fertility. I mean, having a baby is an important thing. So, yes, many women can go, yeah, I can shave this hair. I don't have to worry about that. But when they can't have a baby, it becomes a bigger issue. But in reality, as doctors, we should be treating PCOS very early, from the point these women usually start a period. And if your daughter has irregular periods and your daughter starts showing signs of this, it's very important to get her on medication because you can prevent all those symptoms I'm telling you about with certain treatments that we'll go into in a minute. But before that, I want to explain why you have all these possible symptoms with this syndrome. The reason why is PCOS is really metabolic syndrome. Metabolic syndrome is a genetic issue that's passed down with families. Matter of fact, PCOS is extremely genetic. When we look at monozygotic twins, which are twins that are identical, we see a high incidence of both sisters having PCOS, 71%. However, when you take dizygotic twins, which are basically fraternal twins, not identical, there's only a 38% chance of correlation that both will have PCOS. What this means is there's a very strong genetic component. It's not just in utero, but a genetic component that's passed down. Now, I'm not going to get into the really details of where this genetic problem came from. It's very interesting, and maybe I'll do a podcast on it. But essentially what it comes down to is years and years ago, we didn't have as much food as we have today. And so our ancestors didn't eat as much food. They had lower calories and different diet. Today, we have so much food, we're throwing it away. And unfortunately, our bodies, from an evolutionary standpoint, have not been able to change fast enough. And so some of our bodies react different when we eat extra calories or overeat. This creates inflammation, and this inflammation causes further insulin resistance, causing further inflammation, and basically creates a state that increases heart disease, diabetes, and many of the things we see people dying of all the time. For women, if they have this, it tends to cause their ovaries to become polycystic. This likely has something to do with a mechanism that's being increased, causing this phenotype in their ovaries. We don't believe that the polycystic ovaries is causing the metabolic syndrome, but that the polycystic ovaries are a reaction to the metabolic syndrome. So how do you treat this? How do you get rid of polycystic ovarian syndrome? Well, you can't get rid of it. Unfortunately, it's just one of the bad genes that your family passed down to you and you have to have. But that doesn't mean that you have to have all the complications from PCOS. Those you can treat and you can manage. So before we go into the treatment of PCOS, I think it's very important to understand that PCOS is a spectrum of a disease. Just like you have spectrums in autism, you have spectrums in PCOS. On one end of the PCOS spectrum, you have women who get a little bit of acne, have polycystic ovaries, and we call them PCOS. On the other end of the spectrum, we have women who never get a period, who have type 2 diabetes, have a full beard, and have pretty much heart disease, and they also have PCOS. And so when you talk about treatments also have to be designated to the right person. Essentially, there are 5 treatments when it comes to PCOS. And depending on whether you're looking at it from a fertility standpoint or looking at it from a medical standpoint, you would do things different. The first treatment, which treats every single symptom of PCOS, is lifestyle changes. Now, lifestyle changes means ways to reduce inflammation. We're not talking about weight here. Now, yes, it does help to lose weight, but that's not what I'm talking about. Even someone who's thin can benefit by reducing the carbs in their diet, and that will lower the inflammation rate. Because remember, the metabolic issue is the calories and in some situations, the carbs. Now, when it comes to specific diets to help with the lifestyle changes, there are 2 diets that have been known to help women with polycystic ovarian syndrome. The first is caloric restriction. This means lowering your calories. This is going to be your Weight Watcher type of diet. You're counting your calories, and that is going to help reduce the inflammation in your body, which will then lead to things like weight loss and reduce some of the issues that are associated with PCOS. The second type of diet would be a keto diet. A very low carb diet will also reduce the inflammation. And by reducing the inflammation, you will remove most of the metabolic issues associated with polycystic ovarian syndrome. Now, what's interesting is if you are overweight and you have polycystic ovarian syndrome, sometimes losing the weight can make most of the symptoms of PCOS go away. Now, if you're thin with polycystic ovarian syndrome, you can't obviously lose any more weight. But doing those diets and reducing carbs or low calorie diet could lead to lower inflammation and can help improve your PCOS symptom. Now, I want to take a moment here to talk about obesity associated with PCOS. It is true that over 50% of people with PCOS do have obesity or are overweight. And unfortunately, one of the things that has happened is that many doctors see women who are overweight and assume they must have PCOS. And they put tons of focus on the patient's weight. I've even had fertility doctors refuse to treat patients until they've lost the weight. These are even women who are 42 who don't have much time left and tell them they won't treat them until they've lost the weight. This is wrong. And the reason it's wrong is it is very clear it is not the weight causing the problem. It is the disease causing the issue. Even the weight that you have is caused by the disease. So what I'm saying is, if I take 2 women, exactly the same weight, same height, but one has PCOS and the other doesn't have PCOS, the one without PCOS would have none of the issues that the woman with polycystic ovarian syndrome has. She would be able to ovulate on her own. She would be able to get pregnant. She wouldn't have to worry about hirsutism. She wouldn't have to worry about getting acne all the time. She wouldn't have to worry about the heart disease or the diabetes. Why? Because it's not the weight that's causing the problem. And unfortunately, many doctors have focused on this. And the thing is that they make women feel as if they caused this. And it is 100% clear that that is not the situation. And as a matter of fact, even our own society now states that people should be treated immediately if they're older, and that weight loss should not be the first line treatment if there isn't time for weight loss. I'm not saying that weight loss isn't good. Yes, women who are overweight and obese with polycystic ovarian syndrome will benefit from weight loss. But my point is 2 points. The first, if you're older or you want to get pregnant, you should just be treated to get pregnant. If you have time to lose weight, that's great. That's only going to help your pregnancy. But most important of all, do not blame yourself and think that you caused this. You didn't cause this. Unfortunately, you were born with this metabolic syndrome. And unfortunately, it has now caused you not to get pregnant. And in my view, no woman should ever be told she can't get help having a baby because she's overweight when the weight isn't even the issue. The weight's just causing the issue to be a little bit worse, but it's the disease they have. That would be equivalent to a doctor refusing to treat someone with an asthma attack because they also smoke. That's unethical. And it's unethical in this situation too. The second treatment in PCOS is birth control or medications that induce your period. As I mentioned earlier, it's important to have a period approximately every 3 months to prevent endometrial cancer. Now, most women, if they're not trying to get pregnant, will be put on birth control. And the benefit of birth control is twofold. The first, it's going to make sure that you get a period every month. And so that way you won't get endometrial cancer.
Stay with us. We'll be right back.
Hey, Jordan Harbinger here of The Jordan Harbinger Show. Subscribe to the only show that will show you how to apply the world's greatest ideas from the most striking minds. We've got spies and CEOs, athletes and authors from Kobe Bryant to Malcolm Gladwell, Tony Hawk and Howie Mandel, and the chairman of Google, founders of LinkedIn and Instagram, antiquities smugglers, con men, brilliant scientists, national heroes, and even the head of the CIA. Come join and have a listen for yourself. Subscribe right now to The Jordan Harbinger Show, available on Apple Podcasts, Spotify, and wherever you're listening now.
The second benefit is that birth control increases sex hormone binding globulin. And what this protein does is it binds hormones. Specifically, it binds sexual hormones such as testosterone. And if it binds more testosterone, there's less testosterone that is free, which means the symptoms of elevated testosterone will be low. So birth control actually helps prevent those unwanted hairs. One mistake I see many obstetricians and gynecologists do is they put women on an IUD, a Mirena IUD, or they'll put them on Provera to induce their period every month or two. Now, this is okay when it comes to preventing endometrial cancer. It's definitely going to help with that, but it's going to do nothing for the elevated testosterone level because you won't be making sex hormone binding globulin. To do that, you have to be using combined hormonal contraceptive that has estrogen and progesterone in it. The third treatment in PCOS is going against the insulin resistance. These are going to be metformin or Ovasitol. Metformin is a drug that was made for patients with diabetes. And what it does is it lowers the glucose levels in your body. Now, by lowering the glucose levels, you lower the insulin levels, and that helps. So metformin, kind of like lifestyle changes, helps everything, even your fertility. However, metformin has some horrible side effects. Indigestion, flatulence, sometimes stomach pains, all the things women want. So many women now are starting to use a vitamin called Ovasitol, which is myo-inositol. Now, the evidence isn't clearly out there yet to say it's as good as metformin, but the thing is women can tolerate it. And if you can tolerate it, you're going to take it more and it's going to help things. I see many doctors put everyone on metformin. And I traditionally do not put everyone on metformin. Matter of fact, I look for symptoms that show they have insulin resistance, such as acanthosis nigrans. That's that dark coloring I mentioned earlier that can be on the back of the neck, under armpits, or sometimes in the groin. If you have that, then you definitely have insulin resistance. Now, if I don't see that and I still want to see if you would really benefit from metformin, then you can do a 2-hour glucose tolerance test. And that will test if your body can metabolize glucose well enough. If we found you can't, then you would also start metformin. But again, I do not like to start people right away because it's not a fun drug unless you find flatulence fun. The fourth treatment is going directly after the elevated testosterone levels using anti-male hormones. These hormones are things like finasteride, flutamide, or the more common one that everyone uses, spirolactone. Spirolactone is an actual blood pressure medication, but in higher doses, it will actually lower the testosterone level. And the way it does that is it blocks the conversion of testosterone to the stronger version of testosterone called DHT. So testosterone is what causes your issues. So taking a medicine that blocks testosterone will block some of those issues. Now, every doctor is a little bit different. Most doctors are going to start with birth control. And if that's not keeping your hairs from coming back and causing some of the unwanted things you want, then they add spirolactone. I'm a little different when it comes to this. Personally, if I was a female and I knew I was going to grow hair on my face, I don't want to start with something that may not work. So I personally start everyone on spirolactone if they have some dark hairs with the birth control. And then if they want, they can come off of it later. But I personally feel like I don't want this woman having hair on her face. I don't even like shaving. Why would she like shaving? So I start everyone on it right away. The last treatment is fertility medications. Now, as I said in the beginning, this is not a fertility problem. It's a medical issue. And the way you can get someone to ovulate is you give them medications that induce ovulation. The medications we tend to use are going to be Clomid and Femara. Now, when it comes to polycystic ovarian syndrome, it has been shown that Femara is actually better than using Clomid and even better than using Clomid with metformin. There was a time where people used to use metformin. If your doctor is putting you on metformin to help you get pregnant and nothing else, they're using old literature to treat you. In the past, we thought metformin was going to be this perfect drug that was going to get people pregnant and not have to worry about multiples. However, if you truly do have polycystic ovarian syndrome, you really don't have to worry about multiples with Clomid or Femara because most of the time you don't even make one egg, let alone 2 eggs. But there were studies that have been done to show metformin is not as good as Clomid and Femara, and Femara is better than both. Now, why do people like to start with Clomid before Femara? Because Clomid's been around for a long time. It has a long track history. We can look back and see have there been any issues. Femara hasn't. Matter of fact, there probably are no kids that are even 25 now that have been born using Femara. So for that reason, we don't have a long track record on it. The second thing is that Femara is a theoretical teratogenic drug. What that means is that it can cause problems with a baby. Now, why do I say theoretical? The reason I say that is because what it can cause is it can lower estrogen levels in a developing female by stopping the conversion of testosterone to estrogen. And if you have a female and you're not converting testosterone to estrogen, you'll have an increased testosterone level, which will then cause your daughter to grow a small penis. Now, before you get scared, keep in mind, this is theoretical because the baby doesn't even determine to be a boy or girl until 10 weeks. If you're using Femara, you have stopped using it before you even ovulated. So the chances that you could be on Femara at a time that would cause a problem would be extremely rare. The only way that's going to happen is if you're taking Femara without the help of a doctor and you didn't know you were pregnant and were taking Femara. That's why I always recommend before starting Femara, always check a pregnancy test to make sure you're not pregnant. Now, clearly, fertility drugs for PCOS include more than Femara and Clomid. There are injectable medications. There's things like IVF that are used. I'm going to wait till next week to talk about these things because that's almost an entire show on its own. Women with PCOS don't just have a problem with ovulating, but actually their eggs can sometimes be lower quality because of the inflammation. And so women who undergo IVF usually make lots of eggs, but their egg quality usually is poor. And many women who have PCOS know that they've gone through, got lots of eggs, but ended with few embryos. What I want to end on tonight is just to talk about the most important concepts. So first, PCOS is not a diagnosis, but a syndrome. And because it's a syndrome, it can be associated with other problems. The most important one is endometrial cancer. So again, the most important thing from this is make sure you get a period at least every 3 months. To stop those symptoms, there are treatments you can do. Those treatments are lifestyle changes, which include weight loss, birth control, metformin or Ovasitol, anti-male hormones, or fertility medications. Now, if you're not wanting to have kids, then you're going to want to do the treatments such as anti-male hormones, the metformin, birth control, and the lifestyle changes. If you're wanting to have kids, you can still do the lifestyle changes, but you clearly can't go on birth control. You can do metformin and Ovasitol, but you can't do anti-male hormones because what if you have a boy and you're taking anti-male hormones, now your boy looks like a girl. And obviously then you would take fertility medications. But the other thing I think is important is I want to make sure that everyone understands that weight does not cause PCOS. That PCOS is what sometimes causes the weight. And the weight makes the PCOS worse, kind of like pouring gasoline on a fire. A bowl of gasoline near a fire is not going to cause a problem. You pour that gasoline on the fire gets bigger. That is how weight is to PCOS. If you didn't have the genetic problem, you would have absolutely none of the issues. But because you do have the problem, the weight is like gasoline on the fire. But it's very important for you to understand that this is something you were born with. And that leads me into the last part that I want to talk about, which is the metabolic milieu that occurs from PCOS. See, people with PCOS really have it unfair. Their body is different than most people because for us, our body reacts normal to food and we absorb calories when we need it and we don't absorb calories when we don't. But people with PCOS and metabolic syndrome, their body's in a constant state of inflammation and it's storing those calories more than it should. And as a matter of fact, the food even increases the inflammation, creating a problem. I want to describe that problem, but it's a very complex picture. So try to think of what I'm talking about and see if you can understand this. So the brain sends down two hormones down to the ovary, LH and FSH. LH is what makes testosterone. FSH is what makes estrogen. It converts the testosterone to estrogen. We call that aromatase. Now, usually these are one-to-one relation hormones. So if you have one molecule of LH, you have one molecule of FSH. But in people with PCOS, it's different. It's sometimes 2-to-1, 3-to-1 in favor of LH. And so if you're making more LH to FSH, that means you're making more testosterone to estrogen. And then your testosterone levels rise. Now, what's interesting is that testosterone level, as it rises, causes a thing called insulin resistance. And what that means is that if you have insulin resistance, it means your body, insulin doesn't work as well as someone else's body's insulin. It's like my kids, I tell people, They have work resistance. Usually a job that only takes one kid takes 4 of my kids because they have work resistance. Well, if you have insulin resistance, your body takes more insulin to do the same job as 1 molecule of insulin. So now when that person takes in, let's say, some glucose, which would be food, their body's going to make extra insulin. Well, what's the big deal with that? Well, unfortunately, insulin then causes the ovary to actually make more testosterone, which then causes more insulin resistance. That insulin resistance causes the pancreas to make even more insulin. And then that over responds and makes more testosterone. And then that insulin causes the fat cells in the body to increase because insulin is a growth hormone and you gain weight. And those fat cells also cause insulin resistance. And those fat cells also cause testosterone levels to rise. Now, all of a sudden, you have elevated testosterone, you have increased insulin resistance, and you have this horrible cycle that's occurring that you can't stop unless you treat the root of it. You have to stop the metabolic portion. Now, next week, we're going to talk about how all these medications attack that metabolic milieu I was just talking about and the way you can fix this. As always, I really appreciate everyone who listens. I appreciate everyone who reviews us, who tells people about us, and builds us up. Until next week, this is Talk About Fertility Tuesday.